maybe push licensure in certain areas for surgical techs and really trying to advance the profession. And certification it's not a big deal to some people, but it really is. I just feel like, how can we advance as a profession if we're not pushing to, make sure that our students take certification and pass it?
Clock in, scrub up, and join us behind the red line. You're listening to First Case, a perioperative podcast bringing you exciting interviews, engaging discussions, and innovative solutions that are changing the way patients receive surgical care. Each episode, we talk to frontline staff, perioperative leadership, and nursing entrepreneurs from across the country as they share their stories, experience, and expertise on the industry we love. From the back table to the boardroom, from wheels in to wheels out, we tackle the real-life issues affecting the OR. Whether you're tuning in for surgical service education or inspiration, we're glad you're here. And now, it's time to roll back and start the first case.
This week on First Case, we speak with Megan Mullinax, a certified surgical technologist working in Birmingham, Alabama at a large academic medical center. She has been scrubbing for almost 8 years in regular OR with a brief stint in labor and delivery. Primarily, she scrubs the urology service with some robotics, and she was also adjunct faculty at a local community college for 3 years and used to work with a medical school in Birmingham, teaching medical students aseptic technique. And so, Melanie, I'm really excited to have our very first scrub tech on First Case, and it definitely is not going to be the last time, but we're really going to just introduce the audience to what education is like, what the training is like, what the certification is like, and then what the experience truly is like from a scrub tech's perspective.
Yeah, Justin, I'm really excited to get to talk to Megan. I think that interviewing a surgical tech is something that's a long time coming for our podcast. We've talked to so many other people, but to hear what it's like from a surgical tech's perspective is just very valuable. They do so much in the OR, to hear what they experience and what they experience every day and see what the workload is like for them is going to be exciting. And I'm looking forward to hearing what she has to say.
All right. Well, we're going to be right back after a short break with Megan Mullinax.
You're listening to the First Case podcast.
Joining us now is Megan Mullinax, certified surgical technologist, and a long overdue appearance, to be honest with you. Getting a scrub tech's perspective today, Megan. Thank you so much for coming on the show.
Hey guys, thank you so much for having me.
So why don't we start? We always read this bio at the very beginning, but why don't you just talk about your passion for surgery?
So I just so happened to come upon surgical technology. I didn't know what it was when I started. I just did it to do it at the time. And so it turned out I ended up loving it. The patient care that we give is it's not common. We're the only ones that do it. It's just, I feel that we're highly specialized. And so I just love it. I love assisting surgeons. It's just a different field as part of medicine. So I just love it.
You know, Megan, when I came into the OR 10 years ago, I didn't know that there was any other setup besides scrub tech scrubbing and nurses circulating. I was hired as a circulator, and that's what we did. We weren't trained to scrub. And nurses who worked there really weren't even allowed to. Just scrubs did their role and nurses did theirs. But as I worked in the OR, I kind of learned that wasn't always the case. Can you talk about or explain more of this, how the scrub tech role came about and maybe how it's evolved since it began?
Sure. The surgical tech role came about during war times, starting in World War I and World War II. Nurses at that time were not allowed on battlefields or on battleships if they were in the Navy. And so the Army and the Navy created positions to fill this need of someone to assist the surgeon. So the Army trained medics to act as surgical techs, and whereas the Navy had corpsmen that could do that job. So, and over time, with more wars coming, especially in the Korean War, there was a severe shortage of operating room nurses. And so hospitals began to reach out and recruit these ex-military trained personnel to come and work in civilian ORs. And so you've gone from operating room technicians is what that role was called earlier on. And so with the advancement of surgical technology and things, it evolved into the surgical technologist role.
As military members were being recruited into hospitals to work as surgical techs, was there more education and training that was needed in order to solidify that as a surgical tech role? Or can you talk about education that was required and then how it evolved into what we have today?
So I really don't know. I'm assuming that before formal programs were established, that hospitals just had their on-the-job programs to train people. I can't say for sure what those programs were or how that education developed. I do know that formal settings for education started in about the late 60s and early 70s. Institutions and colleges and hospitals began forming their own formalized programs for surgical techs.
So, Megan, one of the things about the training in the operating room is really none of it is formalized. Most of the training is done on the job. And you were just talking about how most people were military trained and that was on the job types of training. But then yet really the only formal education and schooling around surgery and instrumentation is the surgical technologist programs. Can you talk about certification and how important that is and why it makes the profession so unique from maybe some of the other folks, with the exception of the surgeons in the OR?
Oh, I talk about this all the time. Certification is so important. Even on AST's website, they talk about the legislation that they are going through to try to maybe push licensure in certain areas for surgical techs and really trying to advance the profession. And certification it's not a big deal to some people, but it really is. I just feel like, how can we advance as a profession if we're not pushing to, make sure that our students take certification and pass it? And even if you're working and not certified, pushing yourself to study and go back and take the test. I think it is so important. It's so good for the profession, and hopefully that we can move forward and maybe someday be licensed or have to register like maybe nurses do, state by state. So I can't say this enough. It is so important for the profession.
Can you talk a little bit more about what's involved in getting certified?
So there are different ways that you can be certified. And they're doing a little research for the podcast. I found out there are actually 3 certifications that you can get. I knew of only 2, like my whole surgical tech career. So the first that I can talk about it's more widely recognized. It's the Certified Surgical Technologist credential, abbreviated CST. And that credential is issued by the NBSTSA, which is the National Board for Surgical Technology and Surgical Assisting. That is a nationally recognized certification. I do know that more hospitals recognize that one than the other 2. To be eligible to sit for that certification, you have to be a graduate of an accredited program, or I think if you have military training, you can sit for that certification exam.
So, Megan, can you tell us about the 2 that are lesser known?
Yes. So the other, probably almost as popular, is the Tech in Surgery Certified Credentialed, which is abbreviated TS-C. And that is given from the NCCT, and I believe that is the National Center for Competency Testing. If I'm wrong, don't shoot me, but I'm pretty sure that's what it is. That certification is good for people that are experienced, whether they were on the job trained or they didn't go through a formal program. You can use relevant experience and documented experience to be able to sit for that certification exam. And that agency also accepts military training, I'm pretty sure, or a graduate of an accredited program. I say lesser known. I have heard that not as many hospitals recognize that certification, and that's why I say that. I don't think it's inferior. People have accused me of saying that. I don't think that. I'm just saying, from what I've seen, I don't think as many hospitals recognize that certification.
So, Megan, how long is the CST programs that are out there, generally speaking, and how do they differ from an RN program?
So it depends on what institution you go to as to what their surgical tech program looks like. For the most part, they're either an AAS, an Associate in Applied Science degree, or some sort of certificate program, which would be 9 to 12 months, depending on the school. I don't know what the basic requirements are or prerequisites for the AAS degrees, but those would definitely take 2 years if it's an associate's degree.
So I've seen a lot of different schools out there in my experience, and there's a lot of variation between how they approach the hospital and for getting their students' experience. So what do you think is the best approach for the CST schools to integrate their programs with hospitals? How do they make sure that the students are getting the information that they need and are able to perform up to standard when they graduate?
No hospital is obligated to take surgical tech students. That's just kind of a courtesy that they extend to the colleges by taking surgical techs for clinicals. You know, we just approach these hospitals and basically just ask really nicely if they would like surgical tech students. If you are an accredited program, you have to show that you have enough clinical spots for each student that you have. And so it is a process to make sure that you have enough hospitals lined up and enough spaces in place for these students to go to. So it can be tricky, especially if hospitals stop taking students or other things happen. But for the most part, hospitals are very welcoming for surgical tech students because that's potential employees one day. So usually we don't have an issue with securing spots for students.
Agreed. But what about the on-site time of the instructor? And how does the instructor ensure that student is getting the experience that they need? Do they have to spend so many days a week at each hospital, or how do they get feedback on those students from their preceptor, or however? Does that vary?
It does. Each program does clinical rotations and lab time their own way. There's just certain standards that are set forth, and as long as you're meeting those standards, it can be set up however they see fit. At the program that I taught at, the first semester was a lot of book work, but it was also very intensive lab time. Tons of aseptic technique and practicing sterile setups over and over again. As far as when they get into the hospitals, we sent our students to 3 different hospitals. I think it was 6 or 8 week rotations. I can't remember exactly. So they're not with the same preceptor all of the time, but we get evaluations from those preceptors. And so we kind of judge by those and feedback that we get from the hospitals on how our students are doing. And backing up a little bit, if we see poor performance in our students, or we don't think they're getting it, or if they're really struggling, especially with aseptic technique, we don't even let them into the hospitals. It's definitely a safety issue. So I guess just a number of things ensure the students are getting the education and the skills that they need.
So Megan, let's talk a little bit about scrub techs once they do get into the hospital and they're working. Can you talk about the roles and responsibilities that they have within the OR?
Yeah, so each hospital has their own thing, I'm sure, for surgical techs, but for the most part is setting up and creating and maintaining a sterile field, assisting surgeons during procedures, assisting with patient positioning and patient transfer. I know in some hospitals, surgical techs go and get the patients from the floor or from pre-op and maybe take patients to PACU, maybe not take them to PACU, but turning over ORs if you don't have that kind of support staff, even up to like cleaning and stocking rooms. Just a lot of it depends on where you work. The basics are definitely assisting the surgeons, setting up and creating a sterile field.
So let's talk about the relationship with the surgeon. And when I met my wife, she was a surgical tech at an eye surgery center. And I remember that she worked with one of the particularly picky surgeons who did not allow, and I don't know if I put that in quotes or if that's straight up the way it was, but did not allow many of the scrub techs in the facility to do his cases. He really had a very limited number that he would, allow to do that. And my wife was one of them. And so, I just remember how difficult that sometimes made it for the organization, like when she wanted to take vacation. It really handcuffed them. Can you talk about relationships with the physicians and, maybe some examples of healthy relationships and then some examples, like the one I just shared that may not be as healthy?
So when you start working, and I call it a home, you have a home when you're with these same doctors or the same service all the time. When you're with these doctors just 16 to however many hours a week, you can't help but to form some kind of relationship with them.
You're side by side all day. It's almost like a marriage.
Oh, for sure. That's such a good descriptor for that. It's like a work marriage.
Have your work wife or your work doctor, work husband?
Yes.
So like a work marriage, sometimes there's jealousy involved in these relationships, that the regular work wife doesn't want to let the new girl in to learn how to scrub these cases, right? So have you ever been in that situation?
Yes.
And how do you deal with that? I mean,
Yes.
that can be a really tough issue.
So I dealt with that more as a student at a certain hospital that I was scrubbing at. This girl did not want orientees, did not want students, just so territorial about her doctors. And I just want to say, look, I don't want this man. You can scrub for this man all you want to. I just really need to learn. So, if they don't want you in there, they don't want you in there. Being a student, I just kind of avoided it, I guess. But, it becomes difficult at work when that's the attitude, like, oh, nobody else can be in my room or nobody else can come in here. It kind of does make, not hurt feelings, but definitely makes work relationships difficult, with your coworkers.
Well, it also is not really great for the surgeon when their work wife is away too, as Justin was saying. So that really can be a problem for them, but they don't seem to get that when you're around, right?
Oh, for sure. When they're set on working with the same people, that's fine when those people are at work. But when those people are off for whatever reason, it really puts strain on the staff that end up being in there that day. Especially when they don't want you in there, that this doctor wants his people. It really is discouraging, I would say, for the most part.
Yeah, I think it can be really discouraging for the other staff that have to come in the room. I work with a particular surgeon who's very picky with the scrub tech he has on Fridays, and he wants her in his room at all times, and he gets upset when she takes a vacation that he didn't know about, even though she works for the hospital, not for him. And it can be very frustrating for her, feeling like she always needs to be there. But then when new staff come in the room who are perfectly capable, they sometimes don't get treated as if they are just because the surgeon's uncomfortable with them because he doesn't know them. What do you think is a good way to maybe help that, or help those scrub techs that are walking into these kinds of rooms, how to help, boost their confidence maybe?
If you are going into that situation and you know that you are good at your job, just be confident in that. if this doctor wants his people, he's probably not going to be happy. I know this sounds terrible, but he's probably not going to be satisfied with what you're trying to do. Just know that you probably are doing a great job. He's just dissatisfied and is just going to be because that's how he wants to be. I know that's not good advice, but that's just how it is, I think.
I think sometimes acceptance is a good thing, though.
Yes.
One of the things I typically suggest to my clients is that if you're in a situation like that and your favored technician is going to be away, to bring somebody in extra for a week or two prior to that departure and have them orient with the person that's the usual favored technician and have that person tell the doctor, I'm going to be away for 2 weeks, so I'm going to make sure that Mrs. Smith here knows everything that I do and will be here while I'm gone.
Oh, yes, that's always. I do think we try to do that at work sometimes when we can, but I will say, just in my experience, if a doctor that I work with is going into another OR or following another surgeon with another team in there, I write cheat sheets out, or I try to run in there and help those people as I can. I try to support people that are in that situation when I can.
Yeah, and sometimes staffing just doesn't, ideally, we did that, actually. We had a surgical tech who was going out for leave for surgery, and we had a person available so they could work with this scrub tech, and the doctor knew that they were going to be replacing her, and it worked out seamlessly. It was very smooth, and it was very helpful for the new surgical tech, and the other person could leave without worrying about her room not being taken care of. But when we don't have staff, or when staffing's not, ideal, it's hard to do that. But like you said, Megan, providing those notes and supporting your team, even if you're not in the room, if you're giving them the information they need, it is helpful, I think, to set people up for success.
For sure. Definitely makes a better work environment.
I agree.
And you always pick up your phone on honeymoon.
No.
So Megan, what about the relationship between the RN and the surgical technician? What are, there can be great relationships and there can be some that aren't so good. So tell me a little bit about what is the ideal relationship between an RN and a technician, and what are some of the things that can go wrong between the technician and the RN? Where are the challenges between those two roles that you see?
I will say it's definitely easier when, even if you're not, just best friends, but if you are very friendly with each other and respect each other, I think that's a very good foundation to have a good working relationship with each other, especially if you're with each other all the time, several days a week. I do think a lot of breakdown comes about when maybe a scrub feels like a nurse is overreaching, or maybe doesn't respect the surgical tech in their role, or maybe discounts their knowledge or their scope of practice or something like that. I think that is a lot of issues, between the nurses and the scrubs.
So, Megan, sometimes the surgical tech in the room will have a lot more experience than the RN in the room. The RN may not know surgical instrumentation all that well, or know the steps of the procedure all that well. How do you deal with a situation like that where you feel like you're more knowledgeable than the RN in the room? How does that change the dynamics of the relationship?
I do think in those situations, it can cause a lot of, I think resentment may be a strong word, but maybe some hard or hurt feelings when, especially a new nurse just thinks, oh, I'm the nurse, I'm in charge, which is true in a way, but, I'm in charge of the sterile field. I know what's going on. And so I think if a nurse is just insistent on something or wants me to do something a certain way, or is just pressuring me to do something that I don't want to do or I don't think is right, usually I just do what I think is right, or do what I think is best for the surgeon and for the patient and for the surgery.
And so do you feel like sometimes that surgical techs feel like, they're taken for granted, like they're almost invisible? It's just sort of an expected role?
Oh, all the time. And I don't think every surgical tech everywhere feels this way. And I don't think every RN tries to make surgical techs feel this way. I don't think that's the case, but it definitely is a growing problem and a common problem that surgical techs are made to feel inferior or not good enough for whatever reason. Like, why aren't you a nurse? You should be a nurse. Oh, you're not licensed. And it really is just a dynamic in the OR, especially where I feel the hospital that I work at really pushes that dynamic, even though they don't mean to, or I don't think some mean to. But it's a constant feeling of inferiority and not being good enough, and you're not an RN. It's just a constant battle, it feels like.
Yeah, you really want to see that flat hierarchy where everybody has their role and has something different to contribute to the procedure. And so I almost wonder, you're talking about culture there. Do you ever see like sabotaging going on as a result of a poor culture like that?
I won't say direct sabotaging, but definitely not being as helpful or doing all that you can to help a nurse that may need you or doesn't know the surgeon or know the procedure. I would say not being helpful more than just direct sabotaging. I really don't see that much where I work, but I can't speak for everyone.
So, Megan, I want to reverse this a little bit. What about situations where the nurse has to deal with a tech who may be inexperienced and the doctor has to ask for every instrument during the course of the procedure? At what point in a tech's experience should they be able to anticipate what's needed for the next step in the operation, so that there's a seamless transition between each part of the procedure?
I will say, when I first started working, I felt like I sucked, that I was terrible, that I'm never going to get it. I was working with all these new surgeons. It was a different one every day and doing big cases and small cases. And I just thought, I'm just the biggest idiot. This is terrible. And honestly, just all of a sudden one day it clicked and I started remembering things, and I started, not that I wasn't paying attention, but paying more attention and listening to the doctor teach whoever was with him working. I can't, it's really hard just to put a time on it, but I feel like at least I was working at least a year before I just felt any kind of comfortable with scrubbing on my own and being comfortable with having some anticipation of the surgeon and the surgeries. And that's our job, is to anticipate. And we push that when we teach, and you hear that all the time, to anticipate. And I would just think, how can I anticipate when I don't know what's going on? But it really just comes with time.
I can just speak from my own experience, having scrubbed before I circulated, and I'm hearing impaired. So I had to learn really fast to be able to anticipate what the surgeon needed, because half the time I couldn't understand what they were saying under their mask. So it's really important. And I think there were lots of times where we would do cases where no one would say a word during the whole case. Everything was step by step. Of course, in those days, it was more clamp, cut, tie than now, where everything is done laparoscopically or minimally invasively, and you have stapling devices and things like that that make things go a lot quicker. So
Paul, that's really cool, because you've really seen it from, all sides of the dynamic, whether there's a dynamic at one facility or another or not. You really can understand the various perspectives. I always loved that about your background. And so, Megan, I want to pose this one last question to you before we wrap. And I just wonder what you think the future is. And, I mentioned that flat hierarchy, and, maybe that's the future, maybe not. But if you were to look into your crystal ball and tell us how this is all going to evolve, what do you see?
So I would love to see that one day, that every OR everywhere has that flat hierarchy, that we're all in this together, that all of our jobs are equally as important, and maybe with more awareness of surgical techs, and that most of us went to college. A lot of us are certified, that we have significant, extensive training. Maybe putting that out there and nurses being more aware of that. We can't do our jobs without each other. And so maybe just more recognition of that, and that we're all important. The thinking that just because we're not RNs, we're not as valuable and we're not as important. Hopefully that thinking can go away one day. I hope so.
All right, Megan, really nice job. And I appreciate you really kind of sharing your honest feelings, about that dynamic, because most people out there are living that every day or have had an experience in the past. And I think the more we call attention to it and the more we address it head on, the more likely we are to see that future that you just laid out for us. So thank you so much for coming on the show today.
Thank you so much.
That was Megan Mullinax, certified surgical technologist, getting a scrub tech's perspective, Paul. And I think, we've had a lot of episodes where we just talk about the environment that we're working in. But as we kicked this one off, just the whole evolution of the role of the surgical tech was really interesting to me. And it still stands out in my mind as being really the only role other than the surgeon in the operating room that really has a formal training program that is really built around it, that isn't on the job training, which is a really interesting scenario when you consider just how critical surgery is.
Yeah. And also just getting Megan's perspective on her role and seeing how it relates to the other members of the surgical team, I think was really a great thing to understand from the technician's role. Typically we have RNs on this program. We have to get more technicians on here so that it becomes more balanced in the future.
Yeah, I couldn't agree more. Just increasing that awareness and that understanding and, really empathy for everybody's position that contributes to safe surgical care. But that's going to do it for this week's show. As a reminder, you can help support us by subscribing to First Case on iTunes, Stitcher, Google Podcasts, and Spotify. We'd certainly appreciate a rating and a review because your feedback is important to the show. And on behalf of Melanie, Paul, and myself, thank you for listening to this episode of First Case.